The best part about watching my director scramble to explain herself to the hospital board wasn't the $310,000 offer sitting in my pocket. It wasn't even seeing her spend 3 weeks trying to justify why 4 department heads had formally requested her removal. The best part was knowing she had done all of it to herself the moment she stood up in that conference room and hit delete on 22 months of work that had saved this hospital over $1 million. My name is Marcus Webb. I'm 54 years old, and not too long ago I watched what I thought was the end of my career happen in about 45 seconds. Turns out, it was actually the beginning of the most clarifying chapter of my professional life. But you need the whole story to understand just how completely Sandra Price dismantled her own future when she decided to make an example out of mine. Let me back up. I've been in hospital operations and supply chain management for 28 years. Started as a receiving clerk at a community hospital in Tulsa, right out of college. Worked my way through materials management, surgical services, logistics, and eventually plant operations. I've run supply chains during a hurricane, kept an OR stocked during a nationwide saline shortage, and once coordinated emergency equipment delivery across 4 states when a regional hospital got hit by flooding. I know what it looks like when a hospital is running smoothly, and I know what it looks like when the whole system is held together with workarounds and prayer. 18 months before any of this happened, I took a position as Director of Supply Chain Operations at Meridian Regional Medical Center in Central Ohio. It was supposed to be a step up, bigger budget, larger staff, a facility that had been struggling with operational inefficiencies for a few years. The recruiter made it sound like they were looking for someone who could roll up their sleeves and fix things from the inside. What she didn't mention was that Meridian had already burned through 2 directors before me, both of whom left without much explanation, and that the VP of operations who had brought me in was planning to retire within 6 months. His replacement was Sandra Price. Sandra had come up through hospital finance and had spent the last 4 years at a healthcare consulting firm based in Chicago. She had a corner office full of Lean Six Sigma certifications and a reputation for cutting costs in ways that looked good on quarterly reports. The problem with Sandra was that she had never actually worked in a hospital supply chain. She had analyzed them, modeled them, presented recommendations about them, but she had never physically walked a crash cart through a hallway at 2 in the morning or spent 40 minutes on the phone with a vendor trying to locate a specific surgical implant while a surgeon was waiting in an OR. To Sandra, a hospital was a spreadsheet with beeping. She made her philosophy clear in her first all-hands meeting. Meridian's problems were structural, she said. Departments had developed too many custom processes, too much dependence on institutional knowledge, and not enough standardized protocol. Her goal was to systematize everything so that any competent employee could perform any function by following documented procedures. No more tribal knowledge, no more workarounds. One playbook, consistently executed. I understood what she was trying to do. I even agreed with parts of it. But there is a fundamental difference between standardizing a process that genuinely repeats the same way every time and forcing standardization onto a system that is inherently variable, because human health is inherently variable. Sandra did not see that difference. Or maybe she saw it and decided it was an inconvenient obstacle. Within a few weeks of her arrival, she had restructured reporting so that every supply chain initiative required her written approval before implementation. She instituted a time tracking system that flagged any project going beyond a preset hour budget. And she made it quietly but clearly known that the old ways of doing things, meaning my ways, were not going to survive her tenure. I decided to let the results speak. The first problem I had been working on since my arrival was surgical supply waste in the main operating suite. Meridian was hemorrhaging money on unused preference card items, meaning surgical supplies that got opened at the start of a procedure but never actually used, and therefore couldn't be returned once opened. Every wasted suture kit, every opened implant tray, every specialty retractor that sat on a sterile field for 3 hours and got thrown away represented real dollars. The previous approach had been periodic preference card audits every 6 months, done by administrative staff, who had no direct relationship with the surgical teams. The problem with that approach was that it treated preference cards like static documents when they were actually living records that needed continuous calibration. A surgeon's actual preferences change based on patient population, updated technique, new products, and the availability of specific supporting staff. A preference card written 18 months ago by someone who observed a procedure once is not the same as what that surgeon actually opens and uses today. I spent 6 weeks doing something Sandra immediately pushed back on. I embedded myself with the surgical services team. I stood at the back of ORs during procedures. I sat with scrub techs during their downtime and asked what they actually opened versus what was on the cards. I pulled 2 years of case data and cross-referenced it against actual charge capture to identify the gap. Sandra flagged my hours 3 separate times during those 6 weeks. At one point, she called me into her office and told me that supply chain directors did not scrub into ORs, and that I was creating liability issues for the department. I told her I wasn't scrubbing in. I was observing, which the chief of surgery had already approved. The gaps I was finding were costing us money every single day. She let it go, barely. When I finished, the results were not subtle. By rebuilding the preference card program with direct surgeon input and a new 30-day rolling review cycle, we reduced surgical supply waste by 34% in the first quarter. That translated to $381,000 in recovered annual costs. 3 surgeons who had previously complained about missing supplies actually signed letters to administration praising the improvement. One of the cardiovascular surgeons, a woman who had worked at Meridian for 19 years and had a reputation for not complimenting anyone, told me directly that it was the first time in a decade she felt like supply chain actually understood what happened in her room. When I presented the numbers to Sandra, she looked at them for a long moment. "You spent 87 hours on this project," she said. The allocated budget was 40 hours for a preference card review. We recovered $381,000 annually and improved surgeon satisfaction scores by. The process took more than twice the allocated time, she said. That's not sustainable across our department. If every analyst spent 87 hours on a standard review, we'd never get through the work volume. I pointed out that this wasn't a standard review, that the reason the reviews hadn't worked before was precisely because they were treated as standard when the underlying problem was non-standard. She wrote something on a notepad and told me she appreciated the outcome, but that my time management needed to improve. I walked out knowing exactly where this was going. The second issue came 3 months later through the emergency department. The ED at Meridian was struggling with what the charge nurses called the supply lag problem. Basically, when high acuity patients came in trauma, cardiac events, sepsis, the supply requests that followed were taking too long to fulfill from central supply because the triage process hadn't been designed to anticipate supplies in advance of confirmed diagnoses. By the time a doctor ordered what they needed, it had to travel from central supply on a different floor, sometimes requiring staff to physically locate items that weren't well positioned for rapid deployment. This one had been sitting on Meridian's problem list for 2 years. Sandra's prescribed solution was to upgrade the pneumatic tube system and implement a digital ordering platform that would shave time off the request to delivery window. The consulting firm she had previously worked for had recommended the same platform to 3 other hospitals in the region. Implementation cost: $740,000. Projected improvement: 18% reduction in supply lag. I had spent enough time in that ED to know the tube system wasn't the core issue. The core issue was location and anticipation. When a level 1 trauma comes through the door, you don't need to order supplies faster. You need the right supplies already positioned where the team is going to be working. Sandra had already approved a preliminary budget for the platform. When I asked if I could spend 30 days looking at the problem before they committed, she was not pleased. This was a strategic initiative with board visibility. The timeline was set. The vendor relationship was established. I told her I just needed 30 days. If I found nothing useful, we'd move forward with the platform. What I found was that the ED had 12 distinct high-acuity presentation patterns that accounted for 78% of their supply-intensive cases. Trauma, cardiac arrest, stroke, sepsis, respiratory failure. These weren't random. They were predictable enough that if you staged specific supply kits in proximity to the trauma bays and updated their contents based on actual recent case data rather than 5-year-old clinical guidelines, you could cut the supply lag almost completely for the majority of critical cases without touching the tube system. I worked with the ED medical director, the charge nurses, and the materials team to build 8 rapid response supply carts that were stocked, location optimized, and refreshed on a rolling 7-2-hour cycle based on case volume patterns. Total cost to implement: $43,000 in cart infrastructure and a revised restocking protocol. No new software. No vendor contract. Supply lag for high acuity cases dropped 61% within the first 6 weeks. The ED director sent a memo to the CMO calling it the most impactful operational change in the department in 5 years. Meridian saved the $740,000 that would have gone to the platform. 3 other hospitals in the region reached out asking if they could learn from the model. Sandra called me into her office the day after the CMO's positive response circulated. "You went around and approved strategic initiative," she said. "I found a better solution for less than 6% of the cost. You spent 94 hours on a project I had allocated 30 hours for, and you did it without my authorization, after I had already approved an alternative path. The alternative path would have spent $750,000 on a problem that didn't need software." She leaned back. "Marcus, I need to be direct with you. Your results are not the issue. Your process is. You operate as a lone actor. You pursue your own methods without following established protocols. That creates risk for this organization, and it creates risk for my department. I need consistency. I need predictability. I need people who follow the playbook." I told her I understood. I didn't. The third situation came 4 months after that, this time in pharmacy operations. The pharmacy director, a man who had been at Meridian for 16 years and was about 18 months from retirement, had quietly flagged to me that medication waste was running significantly above benchmark. Specifically, IV medications that were prepared in advance and then not used, either because the patient's condition changed or because the order was modified before administration. Pharmacy waste is one of those problems that lives in a gray zone between clinical operations and supply chain, which means it often falls through the cracks of both. The pharmacy director had raised it twice in department meetings and been told it was being tracked. What it wasn't being done was being fixed. The standard response from Sandra's playbook was to implement a waste tracking module in the existing pharmacy management system. Log the waste, generate reports, identify trends, adjust par levels, clean, standardized, scalable. I spent 3 weeks doing what I had done twice before going to where the actual work happened. I sat with pharmacy techs during their prep shifts. I talked to nurses about what happened when a medication order changed after preparation. I pulled 6 months of waste records and built a timeline analysis showing exactly when waste was highest and why. The underlying pattern was something nobody had clearly documented before: the gap between physician ordering patterns and pharmacy prep timing. Physicians would enter complex IV medication orders during early morning rounds, which triggered immediate preparation. But early morning rounds were also when orders were most likely to be modified, changed doses, discontinued medications, adjusted protocols. By the time the modification came in, the preparation was already done and had to be discarded. The fix wasn't software. It was a 90-minute preparation delay protocol for a specific subset of high modification risk IV orders during morning rounds, combined with a real-time modification alert system built with existing technology. We piloted it for 60 days, refined the order categories based on what the data showed, and rolled it out across the pharmacy. Annual medication waste reduction, $290,000. The pharmacy director told me it was the clearest his monthly numbers had looked in a decade. The CMO mentioned it by name in a board presentation. Sandra's response was to formally document me for spending 78 hours on a project allocated at 25 hours, and for implementing a protocol change without routing through her office for final approval. She said the success was noted, but that the process violations were serious enough to place on my personnel record. That was the moment I understood this wasn't about process. This was about the fact that I kept being right in ways that made her approach look wrong, and she was running out of ways to manage that except by eliminating the evidence. Over the next several months, she started assigning my projects with tighter and tighter constraints. Hour caps that made thorough analysis impossible. Documentation requirements that added administrative burden without adding value. She restructured my team to reduce my direct reports. She moved me out of key planning meetings under the rationale that supply chain involvement was premature at the strategic stage. Then she announced a departmental review. She told me she wanted a full audit of every project I had managed in my time at Meridian. Every hour logged, every deviation from allocated resources, every instance where I had proceeded without her explicit approval. She said it would be compiled as a case study for the entire operations department on process compliance. I knew what it was. I also knew I had nothing to hide. So I spent 4 weeks compiling everything. Every analysis, every decision log, every outcome measurement. When it was done, it was 61 pages, documenting that my total time overruns across all major projects amounted to 312 hours above allocation and that those 312 hours had directly contributed to $1. 4 million in documented annual savings, the preservation of a $740,000 capital budget, and measurable improvements in 3 of Meridian's top 5 quality indicators. I was proud of that document. Not because it was a weapon, I genuinely saw it as proof that a different kind of analysis was possible, and that maybe Sandra could be shown that the numbers actually supported what I was doing. I should have known better. She called a full operations department meeting on a Thursday morning in February. 19 staff members and 4 department managers, plus 2 representatives from the CMO's office. She said we were going to use the audit as a learning exercise in process compliance and sustainable operations. She had me connect my laptop to the main display. She had me pull up the audit document, and then, for the next 30 minutes, she walked through it, section by section, reframing every success as a cautionary tale about unsanctioned resource use, every documented saving, as the result of a flawed process that could not be replicated at scale. She used phrases like heroic individualism and institutional risk tolerance and repeatable excellence versus one-time outliers. She said that a supply chain department that depended on one person's judgment was a fragile department. She wasn't wrong about the concept in the abstract, but she was using it to destroy the concrete. I watched my colleagues study their notebooks. I watched the 2 reps from the CMO's office exchange a glance. I watched Sandra work her way toward the end of the document with the kind of energy that comes from someone who has been building to something. Then she said it. This entire methodology represents an approach that Meridian cannot scale, cannot standardize, and cannot sustain. Effective today, we will be retiring this audit as a reference document and returning to established operational protocols. Her cursor moved across the screen. There was a beat of silence in the room that I think everyone could feel, and she deleted it. Not archived, not restricted access. Deleted from the shared departmental drive in front of 19 people. The room went completely still. I mean the kind of still where you can hear the ventilation system. One of the operations managers, a woman who had been at Meridian for 11 years, was looking at the table in front of her with an expression I can only describe as ashamed. Sandra was already moving on, pulling up a new slide deck, when my phone buzzed. I had been expecting a text from my daughter about a school event. It was not from my daughter. The message was from a number I recognized, a former colleague named Dennis Hartwell, who now worked at Northgate Health System, a regional network that ran 4 hospitals across Ohio and Kentucky. We had stayed in touch loosely over the years. The message said, "We've been watching what's been happening at Meridian. Alan Okafor wants to talk to you today if you're willing. He's the chief operating officer. I'll send you his direct line." I had met Alan Okafor once at a regional healthcare operations conference. Smart, direct, the kind of executive who asked the second question before you finished answering the first. I stepped out of the conference room quietly while Sandra was transitioning between slides. In the hallway, I called the number Dennis had sent. Alan picked up on the second ring. He didn't waste time on pleasantries. He said that Northgate had been monitoring Meridian's operational improvement metrics for the past year as part of a competitive benchmarking process. He said they had a strong hypothesis about where the improvements were coming from. He said they were in the process of restructuring their system-wide supply chain function and were looking for someone to lead it, not execute it, lead it, with full authority to build the team and the methodology from the ground up. He mentioned a number, $310,000, plus performance incentives and full operating authority. I asked him how he knew to call me today specifically. He said Dennis had been at a regional supply chain symposium the previous afternoon and had spoken to one of the managers from Meridian's OR team who had mentioned what was coming. Dennis had texted him that morning. When they saw my name in the circulated meeting invite for Sandra's audit review, they made the call. No spy cameras, no industrial espionage, just a tight professional network and an OR manager who had talked to the right person at the right time. I told Alan I needed 20 minutes. He said he'd be available for the next 2 hours. I walked back into the conference room. Sandra was mid-sentence explaining the new standardized request form that would be required for all non-routine projects. She noticed me come in and paused. "Everything okay, Marcus?" I looked around the room, at the people I had worked alongside for 18 months, at the blank space on the screen where 61 pages of documented work had been a few minutes ago. "I actually have something I need to say," I told her. She tilted her head slightly with the expression of someone who expected an objection she already had an answer to. "I'm resigning from Meridian, effective immediately. I've accepted a position as Vice President of System Supply Chain Operations at Northgate Health System." The silence this time was different. Sandra's posture changed in a way I can only describe as a sudden loss of structural support. Marcus, this is not the time or place for... You chose this room, I said. You invited these people. You deleted my work in front of them. I think this is exactly the time and place. One of the reps from the CMO's office stood up. Perhaps we should. There's nothing to mediate, I said. I was not angry. I was remarkably calm. I documented over $1 million in savings for this organization. The response was a formal personnel action and a public deletion. Northgate apparently sees that work differently. I looked at Sandra one more time. I hope the standardized protocols work out. I gathered my bag, shook hands with 2 of the department managers on my way out, and called Alan Okafor back from the parking lot. He asked how soon I could start. I told him I could be in his office Monday. The first week at Northgate was everything the last few months at Meridian hadn't been. Alan gave me a clear mandate, a team of 8, and a direct line to clinical leadership at each of the 4 facilities. The energy in the room when I walked in was that particular kind of focused excitement that comes from people who have been waiting for permission to do things right. I didn't reach out to anyone at Meridian. I updated my LinkedIn, attended a regional supply chain event, and let the work speak as it always had. What happened next came on its own. 8 days into my time at Northgate, the pharmacy director from Meridian called my cell. He was 2 months from retirement and clearly not worried about professional consequences. He told me that 3 hours after I left, Sandra had scheduled an emergency call with the CMO to explain the resignation. He said it had not gone well. The 2 representatives who had been in the room had already reported back before she got to her office. He also told me something that surprised me, though in retrospect, it shouldn't have. 2 of the surgical services supervisors had independently gone to HR that same afternoon. They had documented their own observations of Sandra's management of my department over the prior months. Apparently, I was not the first person she had treated this way. I was just the first one with outcomes visible enough that deleting them in front of 19 witnesses was impossible to contextualize. Over the following 6 weeks, I got calls from 4 people at Meridian who had been watching what happened. 2 of them were mid-level managers looking for references. One was a materials coordinator who wanted advice on moving into a director role, and one was a surgeon who had been at the hospital for 23 years and who told me, in the flat tone of someone reporting observable facts, that the waste improvement in her OR had begun reversing almost immediately after I left, and that preference card accuracy had already dropped noticeably. I heard through Dennis a few months later that Sandra had been placed on administrative leave while HR completed an investigation into a broader set of management complaints. I don't know what happened after that. I don't spend much time thinking about it. What I spend time thinking about is what Northgate looked like 14 months in. We had reduced supply waste across the 4-facility system by $2.1 million annually. We had standardized what genuinely needed standardizing: vendor contracts, core formulary management, safety stock protocols, and built flexible capacity into everything that needed to respond to clinical variation. 3 of my 8 team members had been promoted. We had received an unsolicited inquiry from a hospital system in Indiana asking if we would consult on their supply chain transformation. Alan gave me equity in a performance incentive structure that hadn't been in the original offer. He told me the best decision he made that year was having Dennis at the right conference at the right time. I tell this to younger operations people who come to me now asking how to handle managers who see process compliance as more important than outcomes. The answer is not to fight that battle in the conference room. You cannot argue someone into valuing what they have decided is a threat. What you can do is build something real, document it carefully, and keep a copy somewhere they cannot reach. Because here is the thing about work that actually matters. It exists in the real world, not on a shared drive. A surgeon's OR runs better. An emergency department reaches its patients faster. A pharmacy wastes less medication. Those facts don't disappear when someone hits delete. They show up in the numbers, in the conversations, in the way people talk about their jobs when they feel like the system is actually working.
Don't pity me. My heart doesn't need your mercy. I can still stand on my own. I was broken by your leaving, fell deeper than I thought I would. But pain has taught me how to heal now and survive what once I couldn't. You don't have to look back sadly. Don't reach out with guilty hands. What you shattered made me stronger. Now I rise where I once collapsed. My heart doesn't need your pity, not another empty sign. I've got enough strength left within me to rebuild this life of mine. My feet are steady through the sorrow. I can stand through all the pain. You don't have to save me, darling. I'll learn to breathe again. I once begged for your affection. Now I've learned my worth in scars. And the man you left in pieces found his own way through the dark. My heart doesn't need your pity, not another empty sign. I've got enough strength left within me to rebuild this life of mine. My feet are steady through the sorrow. I can stand through all the pain. You don't have to save me, darling. I'll learn to breathe again. So keep your sympathy behind you. I don't need what's left undone. Sometimes losing who once broke you is how healing has begun. My heart doesn't need your pity, not another empty sign. I've got enough strength left within me to rebuild this life of mine. My feet are steady through the sorrow. I can stand through all the pain. You don't have to save me, darling. I'll rise alone again. I'll rise alone again.
Some days feel off, like I'm standing but still falling. A little pain, a little tired, and no one to tell it all to.
There are days that feel unsteady, like I'm drifting out of place. Every step just feels so heavy, with a smile I have to fake. A little hurt I keep inside me, a little weight I always hide, and 1,000 quiet worries I've been holding deep inside. There's no one here to tell it to, no one who would understand. So I carry all these feelings like they're slipping through my hands. A little broken, little lost, trying hard to just get through. All these nights I stay awake with everything I never say to you. I keep walking through the silence like it's all I've ever known. Every crowded room reminds me how it feels to be alone. There's no one here to tell it to, no one who would understand. So I carry all these feelings like they're slipping through my hands. A little broken, little lost, trying hard to just get through. All these nights I stay awake with everything I never say to you. stronger. Maybe I'll learn how to speak, but for now I keep it buried in the parts of me too weak. There's no one here to tell it to, no one who would understand. So I carry all these feelings like they're slipping through my hands. A little broken, little lost, trying hard to just get through. All these nights I stay awake with everything I never say to you.